Dave Aron. My relationship to the EDM program has been fairly limited, but very fulfilling because I was Anna Gibson's advisor on a project that related to healthcare and patient safety. Perhaps I should provide a few bona fides. I mean, why am I a practicing physician? And I see patients, I still do. In fact, if you look in, I think it was last month's Cleveland magazine, I'm one of America's best doctors or something like that. Of course, that and a couple of bucks will get me on a rapid transit, you know. Does make my mother happy, though. In any case, I've had a career in an interesting world, the biomedicine and biomedical research world, where fundamentally prestige is inversely proportional to the size of the unit that you study. So the top of the food chain, okay, the people who get the most prestige is molecular biology, okay? And then you go to, you know, maybe a tissue or, you know, or an organ, and then a person. Just the thought of it gives me the willies. And then, you know, if you're really bad, it's populations and public health. Well, I started out doing molecular biology, and I did bench research for 15 years. And after an epiphany and taking a program somewhat similar to this, I commuted from here to Ann Arbor for a master's in statistics and epidemiology. It is 3 hours and 10 minutes from the Cleveland VA hospital to the Motel 6 on State Street. And I can tell you, I was there a lot. My car knows the way. I don't have to do anything. And I have completely switched my career towards much more in the way of management. So I was associate chief of medicine at the hospital. I was chief of medicine for a couple of years. I'm now an associate chief of staff. And my research has switched all the way from molecular biology, okay, to public health and trying to improve the quality of care for our veterans in Veterans Health Administration. And I guess one of my problems, my former boss said that I had this wonderful talent for reinventing myself. Okay, now to me that just meant I failed at a lot of things, okay? It's everything is spin, you know, it's all spin. So maybe it's because I have a short attention span, I'm in my 35th postgraduate year of training, you know, it's that kind of thing. So among the things that I've come across is this idea of complexity theory, and that's really what I'm going to talk about today. Do feel free to interrupt. However, you should know. First, the disclosure, since I work for the VA, I'm full-time, government bureaucrat, GS-15, that what I say is my own opinion. But also, I'm a follower of the Greek cynic Diogenes, who was right there. Diogenes spent his life looking for an honest man. And Diogenes said, of what use is being a philosopher if you don't annoy anybody? And I figure if by the end of 2 hours I haven't annoyed you, then I'll have to come back because there's work to be done. So here's the outline of what I thought I would discuss, although who knows what's going to actually happen. And I do mean it. Please feel free to interrupt anytime you want. Talk a bit about some of the characteristics of complexity, some problems related to diabetes care, from the individual patient all the way up to society as a whole, in the course of which discuss some of the conventional responses, and then try to answer what, if anything, complexity theory has to offer. And try to answer the question, is it management help or hindrance, solace or snake oil? And in fact, if you want to just, you know, open your laptop, spend the rest of the time surfing, the answer to the last question is yes, and that's it. So our first problem is, what is complexity theory anyway? Well, it's not an it, okay? It's plural. It's really a loose set of concepts, orientations, rules of thumb, analytical tools, a whole mishmash of stuff, which makes it very difficult to interpret the literature in any meaningful way because people throw terms around rather willy-nilly. Fundamentally, though, it is an approach to looking at systems. Okay? And you can cut a cow in half, but you don't get two cows because a cow is a system. Okay? And it depends upon, or there are interdependent parts. Okay? So the whole concept of systems thinking, which to my mind underlies complexity theory, is the focus not on the individual parts as much as the whole. So the characteristics, interconnected and interdependent elements. Okay? This should start to seem like things with which you are very, very familiar. And in fact, many of the characteristics of complexity I would just put in the basket of common sense. Okay? Feedback. Okay? When you're laughing at something I say, okay, that's feedback. When you're sitting here with your bare faces hanging out looking bored, that's feedback. Okay? And I'm, constantly trying to readjust what I'm doing in order to keep you all entertained. Behavior of systems emerges. This is kind of the holy grail, which is to say that the whole does not equal the sum of its parts. It may be greater than the sum of its parts, it may be less than the sum of its parts, but it doesn't have to be the sum of its parts. So here's a complex environment, multiple agents, they interact. We have, if we think about an organization as a system with inputs, processing, and outputs, there's feedback. All kind of standard stuff, nothing fancy here. Emergence is kind of interesting. We have this concept of flocking behavior. You've seen birds fly around, or seen Hitchcock's The Birds, and they're all flying around in swarms. Well, it appears to be organized by a leader, but it isn't. And in fact, you can simulate it very, very easily with a computer program called Boyds. And if you get on the internet and just search for Boyds, B-O-I-D-S, there are basically 3 rules, okay? Rule number 1 is separation. You steer to avoid crowding local flock mates. Rule number 2, alignment. You steer towards the average heading of local flock mates. And cohesion, steer to move towards the average position. And if you just plug this into an equation, you can see this swarming kind of behavior. Now that's all very nice. It's all very mathematical. If you ask the Boyds how they knew what to do, they wouldn't be able to tell you. But there's a fundamental problem here, okay? These Boyds never stop to eat. They never stop to sleep. They never stop to mate, okay? So this is, like all models, imperfect. It's a termite hill made by a whole colony of termites, okay? Which is the termite with the plan? There is none, okay? They follow a number of simple rules and emerges a termite hill which you would not be able to predict no matter how you looked at the behavior of one individual termite. That's really kind of the underlying key for emergence. So it's the antithesis of top-down control. This is really bottom-up kind of stuff, okay? It has implications for social science. We know that humans, human systems, social systems are extremely complex, which is, and I'll give plenty of examples, but, and Roger's talk earlier was one example after another of this. In fact, there's so much overlap that I was changing my talk during lunch. But you can see very complex swarming even from very, very simple behavior, or behavior defined by very, very simple rules. So a question is, can we discover simple rules of interaction to explain the various puzzles with which we try to deal with in life? Whether it's the puzzle of sustainability, or the puzzle of discrimination, or anything. Excuse me. Number of phenomenon through which complexity manifests. Nonlinear being the most critical. And anyone who, there's a saying, I won't tell you from where, but some of you may know, that if you hammer on a rock 900 times and nothing happens, and you hammer the 1,000th time and it breaks, it's not just that last one that did it. It's everything before, but that's a very nonlinear phenomenon. Nothing happened, apparently, okay, until that 1,000th. Change can be totally disproportional to the effort, and that can be a tiny effort leading to a big change, or a monumental effort leading to no change whatever, okay? Sensitivity to initial conditions. One of the fundamental problems with most of the statistics that we use is they rest on the assumption that events are independent, when in fact we know that our events are very dependent, okay? That's a real problem. And we have another, few other technical terms which need not concern us at the moment. But an example of sensitivity to initial conditions is how this whole concept of chaos mathematically was discovered by Konrad Lorenz, who was doing a computer program trying to predict the weather. And he ran it twice, but one time he rounded off to the 6th significant digit, and the other time to the 10th or something like that. And he ran his program, and eventually things totally diverged. So those tiny, tiny significant digits, minuscule, had tremendous impact on the ultimate outcome. Now, there's a saying in the VA that if you've seen one VA, you've seen one VA. And I can tell you that you can walk into 2 different VA hospitals and get a completely different feel for them. Cleveland VA has 12 community-based outpatient clinics. They all have exactly the same staffing ratio. Okay? I mean, some are bigger than others, but the ratio of nurses and ancillary support to physicians and so on, exactly the same. You go into the one in Canton, and you get a sense of the place. You go to the one in Akron, which has the same floor plan. Totally different, totally different. Why? It's because everyone who's working there has a history, okay? How they came to where they are is important. Okay, so one way of looking at this from a research perspective is to do what's known as a practice genogram. And the same thing would work outside the healthcare field. There's nothing fancy about it. This is a family practice clinic. Okay, this is work of Kurt Stange in the family practice department here, and Ben Crabtree at Robert Wood Johnson Medical School, and I'm not sure where Bill Miller is. So a bunch of MDs, and how long they've been there varies. The relationships they've had with the various personnel. The practice manager passed away in an accident. It's going to have some impact. Okay. So what this is emphasizing, this sensitivity to initial conditions, is emphasizing the importance of context. Okay. Another kind of nonlinear phenomenon is bifurcation. There's some, was there a question or just a sneeze? A sneeze. Gesundheit. Okay, thank you. Things can be going in one direction and there's a crisis, and you go one way or the other, you can't go both. Okay? And we have some more terms. And by the way, I will make all these slides available. I thought I finished this about 5:30 this morning, and I'm going to run through all of them to make sure I've attributed them all, because I do steal, plagiarize, research, you know. But I do want to make sure that I attribute things before I, post them, because I actually got a complaint once that I'd used someone's slide, and I had put the attribution on every single other slide that I did not make up myself. And this person from Australia, for God's sakes, contacted me, not happy, and I fixed it, because it's total oversight. So here's a nice bifurcation. Think about the concept of disruptive technology. Okay, familiar with Clayton Christensen's work? Yeah, okay. So on the performance of some key attribute, something that starts well below an established market eventually improves to the point where it meets the needs of that established market and then wipes out the companies that had previously provided the service because it's cheaper, or it allows less expensive people to do it, or any number of reasons, okay? This has happened in healthcare, okay? The things that we did in general hospitals when I was a medical student, wouldn't dream of doing them in the hospital now. Patient with diabetes, new onset diabetes, they came into the hospital for a week to get some education, get started on medications, learn about the disease and so on. Not anymore. They don't get admitted at all. Everything's done as an outpatient, okay? We have certain facilities that can do things once previously done only in general hospitals. Outpatient surgery, okay? Why do you think the Cleveland Clinic has an outpatient surgery facility? Because it's got to compete with the other outpatient surgery facilities. We can do things in the office that previously were done only in the general hospital. And for our home care friend here, we can do things at home that once you only did it in the office. At the VA, we have these things called health buddies, and the patient sends their glucoses back and answers questions, how they're feeling, how much they weigh, all that kind of stuff, and it goes to this nurse coordinator who's managing all these patients who never set foot in the VA, or at least not very often anyway. Okay. The next critical issue is adaptation. Because things are interdependent and there's feedback, the system adapts and co-evolves. And this is, so when I said that the whole is not equal to the sum of the parts, it could be more or less, and that results may not be proportional to action. How many times have you tried to change something in your organization and it ends up like one of these clowns that you knock over, but it just keeps bouncing back up, okay? And that's adaptation. Now, one of the problems here is the mental model that we bring to it. We're thinking that we do a cause and there's an effect. But in complexity, things are not so clear, okay? Cause and effect are different words, but the effect of a cause can be the cause of an effect in a feedback loop, for example. So does a shortage cause hoarding, or does hoarding cause the shortage? Well, the answer is yes, okay? Does a circular path have a beginning and an end? The next issue is that we think cause and effect with no time difference yet we know things lag, okay? Now this is linear, okay? It's totally linear, but there's a lag phase, okay? And because of the length of the lag phase, that individual is not exactly cognizant of what's going to come and hit him on his head. So again, the effect proportional to the cause? Not so. And we all know this. We can have SARS, the serious adult respiratory syndrome, which put Taiwan into a complete panic. Okay? You can have a few cases that suddenly blossom into an epidemic. You can have actions where nothing happens until you reach a threshold. Now, there are three schools of thought about complexity. There are the champions, there are the critics, and there are the pragmatists. Okay? The champions think this replaces all the old science, it's a new paradigm, it's wonderful, lack of data, no problem, qualitative is plenty. You have the critics who say this is all a lot of hooey, okay? That it is not science at all and really adds nothing. And then we have the pragmatists, okay? And I'm going to be making an argument for pragmatism, which is to say it's wrong, but it's useful. So among you, how many here think, complexity theory and, if you're a consultant, your practice is based on complexity? There are some people like that. Any champions here? So we got a champion, okay? Few champions. Okay, any skeptics, critics? Okay, and the rest of you are either pragmatists or have no opinion whatsoever, which is, kind of the way pragmatists kind of are, right? Okay, so having reintroduced complexity, I know some of you have gotten some of this in the past. I want to apply it to diabetes. Now, why? Okay. How many people here know somebody who has diabetes? Okay, so that's a pretty good reason why. All right. Now, I didn't ask if you had it. I don't want to know. HIPAA, hooray, and all that kind of stuff. But even if you don't have diabetes, it's costing you about $700, okay, in terms of your taxes to support Medicare and so on. All right, that's a good reason. Now, we start with kind of the initial way that diabetes presented and how diabetes was known. No harm, no foul. The first complication of diabetes was death. Kids got it, and about a year and a half later, they died. That was about it, okay? Until 1922, when insulin was purified and administered to the first patient. That's Leonard Thompson. So this kid was that kid before insulin, okay? And we have a mental model. So here's a typical mental model of healthcare. This is the way a lot of doctors think, which is pretty pathetic, but there you have it. So we have hormone biology, and in this case, a deficiency of a particular hormone, okay? It leads to a disease. The healthcare replaced the hormone, and everything's better, right? I mean, it makes sense. So by the 1940s, remember insulin came out in 22, 1940s, if someone got by then, the average age of death for a diabetic who had their onset of diabetes at the age of 10 was about 45, compared to what it had been in 1897, which was less than a year and a half. So that's tremendous improvement. But 45 years old is not, the typical time one would die in the 1940s, okay? And it became clear complications were developing in people who were living longer, that injecting insulin was not the whole answer. That model was nice, okay? Went pretty far, but not far enough. And then another type of diabetes was being seen much more often and presenting in adults and not children, although I can tell you now, even that's changed. So, okay, so we want to go back. Can we go back? Okay. It is, actually, one of the things I teach in patient safety is human factors, okay? And this is ergonomically horrendous. Okay, so so if we start in 1994, you can see that in the yellow, the prevalence of diabetes, 4.5 to 5.9%, okay? And you can just look at the colors, okay? There's 95, 96, 97. Oh, red state, did you happen to notice that? So now here are all the states with the prevalence of diabetes greater than 9%. It's enormous. Yes, sir?
I'm puzzled by the flashing back and forth. Is that because states were right on the line?
Yes.
Or are there changes in epidemiology?
It's probably a combination of two things. The first is just that some states were right on the border, so that they would have an effect of change in population movement. So people moving to the Southwest and things like that. So why? Well, the answer is a different form of sustainability. Okay? 90% of people with this other type of diabetes are obese. So let's look at the map. Here's 1985. Now the yellow here is no data. Very light blue is less than 10% prevalence of obesity. Slightly darker blue is 10 to 14%. Now we've had to add another 15 to 19%. We have to add another category. And now we have another category. Greater than 20% of people are obese. And now another category, greater than 25% of people. Okay? Suffice it to say, it's not getting better. Okay? So this is where we ended up. I mean, it's a tremendous epidemic. Okay? And now we're seeing diabetes in elementary school kids. This kind of diabetes. Okay? I don't, but just wait. So, yeah. Yes. This, what you're seeing, this tremendous epidemic.
Aside from age, so when you have
Yes. Oh, absolutely. Yes. You can distinguish the two. Yes, definitely. Type 1 is relatively uncommon. So all those maps of that prevalence, okay, that's virtually all type 2. Not 100%, 99%, 98%. So the underlying cause is a bit different, but it's not just deficiency of insulin. So that treating the hormone deficiency is not enough. Okay, so now I know we are basking in the alkaline tide following lunch. Everyone's feeling a little kind of, sleepy, and it's okay. So I want you to find a partner, and we're going to do a little thumb wrestling. Okay, now just wait. Just wait. I'll tell you when to start. Now, you all know about thumb wrestling, right? Okay, don't be shy. Don't be shy. Now, what I want you to do Your goal is to pin your opponent as many times as possible in 15 seconds. On your mark, get set, go. Okay, 15 seconds is done. All right. Oh, these guys are having so much fun, they don't want to stop. So, if you add up the number of pins between, for your pair, how many people got no pins at all? Okay? How many got 1? How many got 2? How many got more than 5? Okay? How many got more than 20? Okay. I'd like to thank you for volunteering. Could you? Oh, in my class, everyone's a volunteer. Okay, so I just want you to watch this. Okay? Now this is what I want you to do. Just leave your thumb right there. Okay? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now you can do that to me. Okay, 5 seconds, combined pins are 20. All right? Now, that met the same criteria as this. All I told you, thanks very much, was to, yeah, well, give it. All I told you was to pin your opponent as many times as possible. I didn't say anything about don't let your opponent pin you. You brought that with you. Okay? That was your mental model. Okay? This is true. You know, justice is a device of the weak for controlling the interests of the strong. Let that be a lesson to you. So we get stuck in these mental models, okay? You know? They're lighting those arrows. Are they allowed to do that? You know, as if they're rules. Okay. Now, mental models are another part of the 5 disciplines of Peter Senge's 5th discipline, with systems thinking. And I see complexity as something that, kind of circles all of them. So maybe we need to think about some other factors. Okay, it's not just deficiency, but we got obesity going on. What else? What other factors? It could be genetics, okay? Could be lifestyle, could be the environment. So let me tell you about a little place I've visited about 20 years ago now, my goodness. About 1,500 miles southwest of Hawaii are the Marshall Islands. The Marshalls site of a big battle, a couple of big battles during the Second World War, Kwajalein, Roy Namur. And it's also the site of where we did our atmospheric nuclear testing. Bikini Atoll. In fact, the swimsuit gets its name from the atoll and not the other way around. Okay? Now, so I was out there a couple times as an endocrinologist to follow up folks who had been exposed to fallout. I don't know if someone's throwing me food or they think I need additional sustenance or I don't look fat enough. So I was seeing these folks who had been exposed to fallout, and they get certain kinds of cancer. And in 1900, I went there in 1990. 1989 and 1990. In 1900, the prevalence of diabetes was 0. 0. In 1990, on the developed atolls, where the capital was Majuro, or where our base on Kwajalein is, prevalence of diabetes was 25%. Okay? Now that's pretty fast for evolution. Okay? And this is Ebi. Ebi is 78 acres. You could walk from here to there in about 20 minutes, even though this is about 8 degrees north of the equator, and I don't know if it's as hot as hell. It may be hotter. I mean, it's really something. And I did do that walk. There there's a Toyota dealer on this island. It's true, absolutely. And people drive around. You can't get more than like 10 miles an hour. Not that there's even any place to go, but because there are kids and people running over. The population, 70 acres, 10,000. Okay? So there's something more to diabetes. And this has lots of implications for the issue of sustainability. Did I mention that the average height of these atolls above sea level is somewhere in the 10 to 15 foot range? So they're not going to be here if we really do have global warming to the degree that some people think. So we're in a perfect storm, okay? Policy environment contributes to diabetes. The built environment contributes to it. The commercial environment. Okay, what do I mean by policy environment? In healthcare, we believe in treatment. We don't believe in prevention. Okay, so it's as simple as that. The commercial environment, here's our McDonald's. Now, McDonald's has changed with the times. Okay? 1955, fries, 2.4 ounces, 210 calories. Now, 7 ounces, 610 calories. Everything has gotten bigger. Absolutely everything. Okay? The built environment. So we have a car culture. Okay? In this suburb here, where can people walk? Not to get any groceries. Can't walk. Okay? And then we have how many people fly in and out of Hopkins and go to Terminal D? How many people use the stairs? Don't worry, you'll be paying for that soon. So, I mean, just to give you an idea, the degree of absurdity. Okay, now, with this next one, okay, it is possible. It is possible that the driver has some illness that prevents him or her from walking. It's possible. But that does straight.
Because he didn't get exercise.
Yeah, exactly. Okay. So if we think about diabetes, we've got to think much more about multi-causation. And that's what complexity is really about. It's not this single, A to B to C to D. It's all kinds of things that interact. Okay? And we can, if we want, put this into models. Okay? And come up with coefficients of all these interactions and publish all kinds of stuff, which has happened, and people are still getting fatter. Okay? But, Okay, now let's switch to actually delivering health care. Okay, so diabetes is a complex illness, complex in terms of cost. What about treatment? Delivery of what we know, okay? It's pretty lousy, okay? This paper by Beth McGlynn was published about, actually now about 15 years ago. If you just look at the quality of care, what the percent of recommended care for just diabetes are in squares, that's pretty pathetic. Now, even the best, okay, this is for cardiac care, and Cleveland does pretty well in cardiac care. Okay, after all, we do have the world famous Cleveland Clinic. Can't say Cleveland Clinic without preceding it with the words world famous. But I don't know about you, but in high school, 65 was passing. I mean, this is at best a D, and mostly it's failing. Okay. Now, yes.
Is that primarily because of access? I mean, are some people getting all the care and others are getting none? Or is this in one?
Okay. I'm glad you asked that question. So let's go down right to the practice level. These are practices in Cleveland at 3 systems. Kaiser, Cleveland Clinic, and Metro. And maybe you see a doctor there. These data required that the patient be seen twice by the physician. Okay? So this is of the one seeing a physician. Now, if you're like Health Alliance and half your patients live under bridges, you know, you got other problems. But these are people, all who have health insurance to one degree or another. Okay? Look at the percent of, of the kinds of care. And these are just processes. Forget about outcomes, which also depend upon the patients themselves. Okay? But just processes. Okay? Did they get the recommended things? The star were the best performers. Okay? Now, actually, I'm glad you brought that up, because if we take a look at Metro, okay, so here's a practice associated with Metro, 2 of them, that are stars, okay? Here's another one, nowhere near as good. Here's another one. This is like the second worst, okay? Tremendous variation within healthcare systems. So we're seeing a kind of hierarchical where the behavior at one level is mimicked at higher and higher levels in very similar ways. Yes, sir? You would think that the process stars, and there are a lot of things that go into outcomes, okay? So our frameworks for improvement, you know, we possess knowledge, we implement we operationalize it, we implement it, you know, really linear. It's the just do it phenomenon, okay? It doesn't work. Any of you done kind of standard CQI, see repeated PDSA cycles up the ramp of complexity? Does this in any way mimic reality? This is reality, okay? Nonlinear, not terribly predictable, or at least it's predictable within a range, okay, but only within a range, okay? And this actually describes some things that we did, okay? The traditional model of physicians to improve healthcare is we have to do more research. You'll never find a clinical paper that doesn't end with the words, more research is needed, okay? So full employment for health services researchers, okay? If you look at what actually happens, it takes an average of 17 years to turn 14% of original research into the benefit of patient care, okay? And these numbers these numbers originally were from a back-of-the-envelope calculation, and I was at a meeting at the NIH last month, and a health services researcher redid this with all the best data he could come up with, and came up with, within a year, virtually the same as a back-of-the-envelope. Now, I don't want to give you the idea that, you know, physicians like myself are, you know, just a bunch of old fogies, that, you know, we're totally ossified and it's something unique to us. This is nothing unusual, okay? So in 1590, who is credited with getting British sailors to be called limeys? Anyone know? You know why they're called limeys, right? Because they've got lime juice, okay? Okay, so 1593, first observed by one British sea captain that citrus did good. 1601, Captain Lancaster did a quasi-experimental study. He had 4 ships, it's non-randomized, lime juice to one ship. The other 3 ships did not get lime juice. They sailed from Britain to India, okay? The mortality rate in the ship with 3 tablespoons, it was lemon juice, Death from scurvy, 0. In the other 3 ships, 40%. 40%. I'm sorry? Well, he lived to tell about it. Does that tell you anything? This is the guy who actually gets the credit in 1747 for doing studies to show the benefit of lime juice, okay? And it took another 50 years for the British Navy to actually make it routine. So 194 years after a very convincing level 2 quasi-experimental study, okay? That's how long it took, 194 years to get it into practice. I mean, this is routine, absolute routine. In fact, it's almost a joke that physicians tend to practice vintage of the year they graduated. Okay? Why? All of this is happening within a much, much broader context. Okay? I mean, I'm a physician, I work within a system, that system has certain pressures, I have time pressures, my patients have their pressures. Everything is connected. So when I said I was going to talk about a few problems related to diabetes, in fact, I'm just talking about one problem. It's all the same problem because everything's connected. It just is a question of where you pick to start, and that is the essence of complexity. Okay, let's go move it up to healthcare reform. So this is our typical approach in the US. We discover a crisis. We identify and debate solutions. We do absolutely nothing, or not much. We try to ignore it for a few years, and then we rediscover it. Okay, well, this year, a little bit different, but will the Obama healthcare reform do much? Too much? Enough? In time? And for what? Okay. Everything is connected. That's the point. And the healthcare system is a complex system with many interrelated components. It is impossible to change one component of the system without influencing others. You try to fix one thing, there's another problem. Or, to quote Yuval Reinhardt's iron law of healthcare, $1 of healthcare cost equals $1 of someone's healthcare income. And we want to cut the cost, but no one wants to cut the income. Okay? So what characterizes all these problems, whether it's diabetes, you name it, you know, at any level? The causes and effects are somewhat elusive. Okay? They're certainly nonlinear, they're interdependent, there are delays. It takes a long time before you get from obesity to diabetes, for example, and from diabetes to complications of diabetes. For the healthcare system, is there an optimal state? I'm not sure there is. And history is really important. I mean, you don't find people in the UK branding politicians as socialist. I mean, that's, well, some of them say they are. I mean, it's not a curse in contrast to this country. So we could think about organizations as machines, okay, one thing like a clock, okay, or as organisms, okay, it's another metaphor, okay, these complex adaptive systems. So now some words from our champions. Okay, anyway, let me stop here. How many champions do we have now? We have one. So we have fewer champions. Two? Two champions? 3? I think we had 5. We have so new champions. We have a couple of new champions. Okay. And how many skeptics? I've cured the skeptics. So are all the skeptics now pragmatists? Okay, so you've gone from being critical to having no opinion at all. Okay. I like that, you know. All right, so this is one of the descriptions of complexity that has been used over and over by some of the champions, actually most of the champions that I know of, to describe the difference between simple, complicated, and complex. Simple is following a recipe. You go to a store, you buy a cake mix, you follow the directions, you get a cake. You go to the store again, you get the same mix, you follow the same directions, you get a cake that looks pretty much the same, okay? And you're reasonably certain that's going to happen. Oh, something couldn't screw up for sure, but I mean, you're reasonably certain. A rocket to the moon, it's complicated. A lot more pieces, but the vast majority of them are mechanical. So if the pieces actually work, everything should go well. And in fact, we are reasonably certain every time a rocket goes up. Now, we're not 100% certain, far from it, but we're reasonably certain. In fact, I remember when I was in the Marshall Islands, the Kwajalein Atoll is the largest atoll in the world. It's about 170 miles, 180 miles across. And that's where we test our missiles, our intercontinental ballistic missiles. It goes out of Vandenberg, 20 minutes, 5,000 miles later, into the Kwajalein Atoll. Now, if you're going to do that, you've got to be pretty darn certain that it's going to land in the atoll and not land in the lagoon and not on the atoll. And I remember watching one of these things, a multiple independent re-entry vehicle, 7 warheads we counted going into the, going overhead and landing somewhere in the lagoon that we couldn't see. But you've got to be pretty certain, okay, if you're going to do that. Complex is raising a child. Okay, you raise one child, the next child could be totally different. Okay? And you can get a formula that will justify anything you do. Okay? And you can't separate the parts from the whole. Okay? You can fix, say, the booster portion of a rocket if it's broken, but you can't take off, you can't cut a child in half and get 2 children. Solomon notwithstanding. So, given that background, this is the case that is used. Has anyone heard about the Brazil and HIV? Okay. It is quite an extraordinary story. Okay? But what I'm going to ask you to think about is, what does this say about complexity? Okay? And watch very carefully, listen very carefully to the words that they use. Okay? So in the 80s, Brazil had an AIDS problem that was equivalent to the AIDS problem in South Africa. Okay? Horrendous. The annual per capita income was less than $5,000, so not exactly a particularly well-off country. By 2000, South Africa's HIV rate was 25%. Brazil, 0.6. Okay? Pretty amazing story. Okay? So here's the problem. How do you respond to an AIDS epidemic where you don't have money for expensive drugs, your healthcare system is pretty iffy, you have high levels of illiteracy, and high levels of poverty and hunger? So what would you do? We got managers here, right? Manage a country. What are you going to do? Sir, thank you for volunteering. What is your name and what do you really do? That's okay.
My name is Will.
Okay.
And I cause Rachel grief.
Oh, okay. Well,
You could kill them.
you could kill them. This is true. Bob. Well, I'm coming to Bob, or our business ethicist here. What do you think of that? Yeah.
Well, that is actually, that proposition has been made before.
Yeah. Or
And kill every person with HIV on the planet.
yeah.
So
Or quarantine, or something. Okay. you know. Okay. Not sure, well, it has not gone very far, mercifully. So here are the kinds of questions you have to ask in order to come up with a strategy to deal with this. I mean, this is real, okay? I'm not making this stuff up, okay? So you could ask a question, well, how much is it going to cost to get the drugs, the antiretrovirals and so on? What do we need to do to manage patients who are illiterate, can't read the bottles, okay? Ensure compliance. How are we going to, what are the resources we need to do this or for an effective program, okay? Right, okay. So the World Bank made its recommendations, okay? Some smart people there, some dumb people there too, but some smart people, okay? They said basically it's pretty hopeless. I mean, fundamentally that's what they said. That you can't provide treatment to everyone because the drugs cost too much, and you don't have that money, and you're not going to get it. Okay, you don't have the resources to manage treatment compliance or adherence, and so you should just focus on prevention and let the other people die off, which I guess is a variant of just killing them. Okay. Okay. So Brazil kind of reframed the questions, okay, and said, instead of asking what will drug costs be for our infected population, they said, how can we reduce costs to provide treatment for everybody? It's a different question. It's not how do we get the money to meet these costs, but rather how do we drive the costs down? Okay, what resources are needed? And they approach this for a variety of questions in roughly the same way. And you can probably read these faster than I can read them out to you. Yes?
Reframing is very interesting. How did that come about? Was it one or two people who said, let's think through this? Was it one with consensus? I'm just curious how the reframing was.
I don't know the answer to that.
That's probably where complexity comes in. A random person was a champion somewhere. Something you couldn't predict comes out of nowhere. You come up with something like this, and if they solve the problem, that person could not ask for help. This is the mutation.
Yeah. And we know that there's kind of a baseline mutation rate everywhere.
So a mutation of ideas.
Yes, that's exactly what I mean. That's exactly what I mean. Yes, sir.
Well, interestingly, one thing we know about Brazil is appreciative inquiry is picking up on that. So there's a propensity to thinking in those terms.
Okay.
We didn't hear you. What about that? Can you repeat?
I said that appreciative inquiry has taken off in Brazil in a very big way. And how it fits into that culture.
Okay. Oh, that's very linear. They got appreciative inquiry. It works. So, appreciative inquiry? Okay, where the AIDS rate is extremely high.
And a few years ago, the U.S. government gave our embassy money in South Africa, but did not pass it on to the government because they wanted it to get to the people. And they organized training that went out into the bush. And one of the best success stories is happening is based on a guy who uses appreciative inquiry out in the hinterlands. But also, most of the training there is going into the businesses. They believe if they educate the AIDS education inside organizations, it'll seep out and also seep in, two different ways.
So very much a bottom-up kind of strategy. All right? So in responding, Brazil came up with a very different set of solutions. Okay? Basically, as far as drug costs, they told the drug companies, we don't care about the patent laws. This is a public health emergency. Lower the costs, or we're making generics. And that's it. Okay? They used whatever personnel they had and recruited additional ones. They did things through churches, which we don't use in healthcare enough. Okay? Lots of non-governmental organizations. All treatment was free. The drugs were free. So that eliminates a major barrier from the patient perspective, okay? And it also gets rid of one of those, you're labeled as having AIDS, you carry around these pills, but it's not as big a deal. I mean, you don't want to have HIV if you can avoid it. So this was the conclusion of, this is Jim Bagan, Brenda Zimmerman, and Kevin Dooley, that it took courage, okay, very nice. It took relationships, interconnectedness, I'm willing to buy that. And they lived with the complex nature. Now, what does this have to do with complexity theory? That's what I ask. So we don't have any more skeptics. So let me ask a pragmatist. Is this an example of complexity theory related thinking? Okay, do we have phase space? Do we have attractors? Do we have sensitivity to initial conditions? Well, maybe, but it seems to me much more like taking a vocabulary developed in mathematical sciences and using it as a metaphor. Now, some people, since our skeptics seem to have died off, here is a skeptic, Ian Reed. Ideas may be swamped by the intellectual snake oil of complexity theory as metaphor, easily identified by the absence of mathematical modeling. And you see lots of flip charts and, of course, PowerPoints. Okay? Now, one can ask the question, is all science mathematical? Now, I would argue that it isn't, but that's a very, very important question. Okay?
My confusion about what we're doing here is we've seen an example. My question would be how, if, as a pragmatist, if complexity theory is useful here, who applied it, how was it being applied in order to get there? So,
thank you very much indeed. So let's move up the ladder of rigor. You're good. I didn't even have to pay this guy. Okay, so this is a group. No, that would be unethical. We have Bob here. So this comes from a group at San Antonio, University of Texas San Antonio Medical School, and they looked at the characteristics of complex adaptive systems, interconnections, self-organization, coevolution, so on. Then they looked at various interventions that were being used in family practice clinics, whole variety, and they scored them based on the degree to which they thought that they fit with it, that they had characteristics of complex adaptive systems. Okay, so they made scores. All right, very nice. Then they looked at the outcomes, okay, of these interventions and scored the degree of success. And then they correlated them. And they found that the interventions that had characteristics of complex adaptive systems were significantly more likely to have had positive outcomes. Okay? Let's go up the rigor even more and use systems dynamics. Okay? As systems dynamics, fancy mathematical model, good at capturing time delays, accumulations, some nonlinear causal relationships, and so on. So here's our Dilbert learns causal loops and the unintended consequences of just about anything. So our goal is to write bug-free software. I'll pay a $10 bonus for every bug you find and fix. Well, all of a sudden, there are a lot of bugs appearing in the software. Okay. So here is a systems dynamics model, a very simplified one, okay, of diabetes. And it's actually simpler than it looks, because all this is doing is modeling transition states between not having diabetes to having diabetes that's undiagnosed, to having diabetes, to having complications. And this transitions from one way to the other, and how they are affected by testing and interventions to prevent or treatment. Very, very, very unusual.
Why, without getting us into medical schools, I mean, if somebody's obese, then that tends to result in diabetes. If all of a sudden they lose all their obesity, do they become non-diabetic? Is the problem they can't modify behavior, or is it the irreparable damage?
It's a mixture of both. Suffice it to say that someone who does not, okay, first, very important thing. What is diabetes? Okay? Diabetes is defined as having two fasting blood sugars of 126 or greater. Now that means if you have two fasting blood sugars of 125, you're not diabetic. Okay? So this is a continuous variable which we have dichotomized. Okay, so there are a whole bunch of people who have blood sugars between 110 and 125. Now, if they adopt changes in lifestyle, you can definitely prevent diabetes. Okay? Once diabetes has occurred, you can certainly improve it. Occasionally, you'll just about reverse it. But to completely cure it, I'm not sure exactly what the data are, but I wouldn't hold a whole lot of hope for that. Okay? And with those, putting in your estimates of transitions and the effect of interventions and so on, if we do nothing, okay, the monthly unhealthy days from diabetes per 1,000 patients with diabetes will just get worse and worse. If we do really good treatment, keep their blood sugars under control, you get some improvement. But if you focus on primary prevention, okay, you really decrease the number of monthly unhealthy days because you're preventing diabetes in the first place. And frankly, that's really where we have to make our biggest impact. And it's kind of interesting that the Plain Dealer has now just started this, it's a daily or weekly thing on weight loss. Now, there are a whole bunch of mathematical modeling techniques, okay? And suffice it to say that people are trying more and more to convert the qualitative, to make the qualitative quantitative, okay? There's a problem. There are a lot of problems. One of the problems is that physical laws in general involve averages. You've got Gaussian distributions, mean, plus or minus standard deviations, that kind of stuff. But there are a lot of phenomenon that don't follow this at all. Okay? And that's the danger of averages. Yes, the average depth, okay, is 3 feet maybe, but it's only 1 foot for a lot of it, and then God knows how deep. Okay? The average doesn't help you. If you look at the links between websites, they don't follow a normal distribution. There are some websites that get, billions of hits, and a lot of websites that get almost no hits. And if you plot that, what you get is a curve, that follows the power law. And then if you do log-log transformation, you get something like this. You get a line. So most professors publish less than average. And I'm not talking 50% publish less than average, okay? I'm talking 96%. So the power law, the distribution, is different from a normal distribution, which has relatively narrow tails. Power law has fat tails. It means that unexpected events occur more commonly than you would predict if it followed a normal distribution. You ever been to the beach? You drop sand, make a little pile, keeps getting bigger and bigger, and then, okay? How many grains you add before it plops down follows a power law. You don't get very many really big hills. You get a lot that are really tiny. Yes, sir?
Power law is a common graph like Narwhal about performance for financial lives. That's performance numbers always like that. Look at the net worth, the Forbes 400, and then
Yep.
it's a
Yet we rely on linear regression equations, which make the assumption that the variables follow a normal distribution, or the transfer.
within the Forbes 400, wherever you go, and that's where complexity starts coming in.
Yeah. Exactly, because that's another example of what's called scaling, the same behavior at different levels of a hierarchy. So what does this have to do with management? All right, so here's a study we did in our emergency room. Now, if you look at the time from check-in to the emergency room to check-out, it's going to vary. And it's going to vary depending upon what you have. It's going to depending upon the staffing. The question is, does the checkout time for one person depend upon what happened to the prior person? In other words, is it independent? Does it follow a normal distribution? Or normal after it's, any kind of transformation you want to do? Or does it follow a power law? Okay? And in fact, it follows a power law. And we looked at the data for 2,371 consecutive check-ins to our emergency room and looked at the times and found that it did not follow a normal distribution. What this means is, from a management perspective, is that if we are going to look at the impact of an intervention, we should not be looking at the mean. We should be looking at the slope. Now, I'm not sure exactly how to interpret a change in slope, okay? But it means that looking just at means, which is what we typically do, okay, is not enough.
Doesn't it mean that you're looking at the outliers, the ones that take the longest, and saying how do we?
That's right. That's exactly right. Now, Richard Feynman of physics lecture fame and frozen O-ring or cold O-ring, with decreased flexibility fame, said that people who wish to analyze nature without using mathematics must settle for a reduced understanding. I think it was Lord Kelvin who said, science is, if any science that is not mathematics is just poetry or something to that effect. Okay. Now, I don't come down on the side of St. Augustine very often, okay? But I think these words are actually pretty good. And I think they are reflected in the economics models that have contributed to the recent necessity for bank bailouts. Okay? That mathematicians have made a covenant with the devil. So, I do say always beware. Okay? There are consultants out there who are peddling the idea that they're using complexity that will cure all. Okay? And sometimes the answer is really not complex. Okay? But so keep in mind, as a pragmatist, that looking at organizations as organisms has its limitations. It's a metaphor, but it's only a metaphor. Okay? Organizations are not organisms. In fact, one of the kind of really out there organizational theorists by the name of Ralph Stacey, who did a lot of stuff on complexity very early on, came to the conclusion that there were no organizations. There were only relationships. And he called these complex responsive processes and not complex adaptive systems. Okay? And this metaphor overstates the degree of functional unity and cohesion. And I can tell you, the VA is not exactly a functional unit or cohesive. I'm doing some consulting work for a VA that shall remain nameless, that is probably the most dysfunctional place I've ever seen in my entire life. Okay. So, some final thoughts. Whether you're thinking about this from a management perspective or a research perspective, or management researcher perspective, ask the question, what's the level that you're looking at? What are the interrelationships? What are the networks? Okay? What's the environment? Because these are open systems. They are connected to the environment. We create boundaries for the purpose of analysis. Okay? A certain amount of analytical reductionism is absolutely critical. But be sure you know what those boundaries are, and remember that they are always arbitrary. Time, really important to this, particularly because of the issue of path dependence. Where you are depends upon how you got there. Okay? And this does have very broad applications all the way from the molecular to the societal levels. I believe that, but I think we have a long way to go since it's still quite a mishmash. So these are some this is some pragmatic advice from some of the champions, okay? And it has to do with your mental models. So think about these kinds of issues, the temporal framing, the spatial framing, in somewhat different ways when you do it with complexity. It's just looking at things from a different perspective. Finally, if you think about where to intervene in a system, you can intervene at the level of the structure, the delays, the feedback loops, but finally you end up at changing the mindset, which to me I think is the most important one, because it is, if complexity theory means anything from a consultant standpoint, it suggests that it's the interaction at the bottom that results in behaviors. And in order to alter the interactions at the broadest level, it means changing the way people think. And mental models are absolutely critical. So, could you make this? How come? Doesn't exist. Doesn't exist in 3 dimension? You sure? Willing to put some money on it? There it is. Oh, that could be straight. That's just has to do with the way the hinge was. No problem there. It's just a matter of where you stand, how it looks. See, that bend that you talked about is actually not where the problem. So, snake oil or Panacea? Panacea is the Greek goddess of healing, by the way. Yes?
Coming back to you gave us the answer at the beginning, which is yes. I think there's an analogy to Clayton Christian's three levels of healthcare. And I'm going to make a mess of it, but in intuitive healthcare, which was medical problems that required the most brilliant doctors thinking, and for example, yes. And
I was waiting for that.
and level one would be something that was not complex. It could be approached with checklists.
Mhm.
And I think Clayton Christensen's point is we tend to attack every medical problem as if it were a complex problem, requiring the highest intuitive level of solution, and that's why we wind up with complex solutions that cost lots of money. And so it could be that over-complexifying medical situations, maybe even over-complexifying organizational responses to healthcare situations, could wind up not only with the wrong solution, but an extremely expensive solution, and maybe a counterproductive solution.
And I would argue the other side. I think that's partially correct. We do tend to over-complexify, but we also oversimplify. And the best example that I know is how we measure healthcare system performance and physician practice. Okay, let's say for diabetes. The standard measure that was put out by NCQA, National Committee for Quality Assurance, was a percent of patients with an average blood sugar as reflected by a particular blood test called A1C of less than a number. It's 7, but that's not so important. What's important is, number 1, it's a dichotomy. So we're trying to make something really simple. A doctor who helps a patient go from extremely high levels of A1C to 7.1 gets no credit. A doctor who helps a patient get from 7.1 to 6.9 gets full credit. So in a sense, we overcomplexify and we oversimplify at the same time. And I think that's part of the reason. So what we do is we look at complex problems and try to simplify them, and look at simple problems and try to complexify them.
But now there's another notion of emergence. And now what you just said will inevitably give a emergence of complexity because this is untenable, this form of measurement, the more complicated, more complex form of measurement will come in, and on and on it goes.
That's right. And actually,
That's what it is.
yes, it is. That's true. Oh, did I mention that this measure has resulted in patients' deaths? Well, you know, in any, when I was an intern, my resident was had been a flight surgeon in Vietnam. And apropos of an unfortunate outcome, he puts his arm around me and he says, "Dave, in any major engagement, you've got to expect casualties." So, all right, so we knocked a few people off with this measure. It's all right. Yes, sir.
I mean, what it says to me, there's a view of simplicity on the other side of complexity. So if you use the complexity to understand something and then you go with simple solutions, then what this said to me was, if you want to focus the effort for many of these things, it's at the level of mindset. But you got there through a complex way. Or you know that there's 4 leverage points, and you know that, in the operating room, focus on the people that are staying in there the longest, and if you put your solution there, maybe you ignore some of the others to begin with. So the complexity lets you focus.
Right.
So I don't think it's an either or. I think it's a matter of using it appropriately.
Exactly. It's a both. That's what I mean by the answer to this being yes. It is both and, not either or. It's both of them. And I think as a mindset, as a conceptual model, it has a lot to offer.
Is there any research on the Brazil case as to what some of the unintended consequences of the actions were? In other words, telling drug makers
lower the cost or else. Okay, well, maybe it lowered the cost and AIDS was positively impacted, but did that result in some other action that resulted in a negative impact down the road?
There may be, but I'm not aware of it.
Probably a couple of pharmaceutical companies merged because of it or something.
Yeah. Well, actually, the market wasn't that great. I mean, they still had a tremendous opportunity in the good old USA.
I guess what occurs to me is that in a complex system, you can't isolate to a specific time incident.
Exactly.
And, so a solution to a problem can simply be the beginning of the next problem.
Mm-hmm. So, let's put it this way. The absence of evidence of an effect is not evidence of the absence of an effect. Okay. So let me just tell a little story. This is a story told by Albert St. Georgi, who's a Hungarian biochemist who discovered the structure for vitamin C. Okay. And he told this story about this detachment, an army detachment in the Alps, a reconnaissance unit. And they were sent into this, icy wasteland, somewhere far away from the Jungfrau Joch, if anyone's been up there. A blizzard came up. And for 2 days, the men didn't return. And the lieutenant who had sent them suffered because he thought he had sent these men to their death. But on the 3rd day, the unit came back. Where had they been? How'd they made their way back? How did they do it? And they said, when it first blew up, that blizzard first blew up, we kind of gave up hope and, just sat around and, just waited to die of hypothermia. But then one of us found a map in his pocket. And they figured, oh, great, we got a map. We'll be able to get out of here. Let's make camp. We'll just wait till the snow blows over. So with the map, they discovered their bearings and managed to get back. So the lieutenant said, let's see this wonderful map. It was not a map of the Alps. It was a map of the Pyrenees. So sometimes any map will do. Remember, all models are wrong, but some are useful. Thank you very much. Questions, comments, brickbats?
I keep coming back. One of the things within the healthcare system that's gotten a great deal of notoriety in the last year is the simple set of checklists that the Johns Hopkins professor came up with.
Mm-hmm.
And solving a problem within a complex system. And what he did was he isolated to that problem. And it was a simple solution. And the analogy here was every pilot, when they go to either start up or shut down their airplane, has to go through this checklist. Why aren't we doing that in the OR?
So, yeah,
And
so
again, just because we're in a complex system doesn't mean we should be searching for a complex answer. Sometimes if you isolate down to the problem itself and look for what's the simplest way to answer the problem, it is a simple answer. Not necessarily always a complex.
right, and it may well work, but it may also change other things and have unanticipated consequences that may be good or bad.
You'd be stifling innovation because now you have to go through a checklist. Then what?
But you can just security, you can also stifle innovation by going back to Bill's cartoon, facing the mountain of having to understand all the complexities to working with blind rules. I would like to argue that you could look at the Brazilian situation not as a complex situation, but as the application of a few simple paradigm shifting rules, rather than as a
But
complexification.
it's like ecologists go for work there, and then you try to repeat as always as best demonstrated practice, but it never worked. Except they worked in that because the conditions have changed, the players are
Right.
different, things just change.
Right. So a lot of my currently funded research is about identifying best practices. Okay, now I use that in the title of the grants because that's what the reviewers like to see.
Yeah.
But I know it's a bunch of crap. okay? These, yeah, we are identifying potentially better practices. Okay? There is no such thing as a best practice independent of the context in which it is being conducted.
In view of that statement, could you modify the first part of your statement that all models are error prone, but some
Oh no, I won't. No, I wouldn't change it because consider this: what is the only map that is not a simplification? See, every model is a simplification. And once you simplify, you're taking something out. Okay? The only map that's not a simplification is a 100% life-size replica of what you're trying to map. Very tough to fit in your pocket. Okay? We accept that there are problems, but maps give us what we need. They're approximations. Okay? Yes?
David, earlier on in the presentation, you had one slide, I should have adopted it at the time, where you referred to adaptation and agency.
Yeah.
To what you were
Sure. So in a complex adaptive system is made up of agents, okay, actors, which are interdependent. And any kind of energy from the outside will affect those interactions. Okay, so a new person comes, yes, yes. Yeah. Although, it is personal agency, but they can also be made mathematical in agent-based modeling, where there's a certain degree of autonomy of those particular nodes.
What's you're deeply involved in all of this. What's your opinion of all this whole health? Where's this going to go?
The healthcare plan?
Yeah, is it just creating the basis for more complexity? Is more top down than bottom up, and isn't bottom
Well-
up what works, but it's not too far one way, so it's
Well, first of all, I wouldn't say it's bottom-up only that works. There are things that are top-down that allow for certain local adaptation that work extremely well. The VA is the perfect example. Okay, I've been there 30 years. I mean, quite frankly, from the standpoint of quality care, 30 years ago, it was a hellhole. Okay? Starting in 1995, when Ken Kaiser became the Undersecretary for Health, he led an unbelievable transformation of the VA, such that if you compare quality by all the standard measures between VA and private sector, VA is better for every outpatient
random
measure.
event. One guy, for years nothing happened, one guy showed up. It took a random event.
Yeah, now is that bottom up? Is that top down? Is that a miracle?
You
A
can't
catastrophe?
You can't mandate
Yeah.
that random event from happening. Only
That-
time will mandate, and inevitably.
That's true, but once he arrived, it was pretty top down. Okay? What do I think about what's happening in healthcare? It's really very simple. Okay? Because we start with the assumption that the role of the healthcare system is to provide healthcare. It's not. Okay? And once you forget that, okay, it makes it much, much easier to see what's going on. Healthcare has two roles, healthcare system. Yeah, provide healthcare is one, and provide and rearrange dollars is the other. Okay? And no matter what we do, until we come up with, let me take a step back. What was the expression this morning? Global intimacy? Was that the expression? I mean, that's like un-American. I mean, you know, the concept of environmental stewardship. What did colonists do? What was the first thing they did when they arrived in this country? They cleared the forest. Okay? not exactly environmental stewardship. I think fundamentally we have completely contradictory views of the world, okay? And I think we're gonna be fighting over those contradictory views, the degree of communitarianism versus the degree of individualism. And in Europe, there's much more communitarianism. In the US, much, much more individualism. And I see pretty much more of the same until the system has a catastrophe.
In line with those comments, surprised you didn't talk about prevention.
The only reason I didn't talk about prevention is that I was trying to focus more on management kind of issues, although I believe firmly in prevention. Okay? In fact, from an institutional perspective, when medical schools in the United States became modern, okay, that was after the Flexner Report in 1910, okay, and they adopted the German model of medical school. Prior to that, medical schools had mostly been proprietary, money-making, okay, and anyone could get in, and anyone could get a degree with, many places had no requirements at all, either to get in or to get out, other than paying for, no, they had to pay. I mean, this was money-making, don't misunderstand. Well, at the beginning, public health and physician responsibility were reasonably closely linked. That changed. So that in the US, we have medical schools and we have schools of public health, and the twain do not meet. We had a dean at the medical school, dean prior to the current one, who strongly believed that we needed to bring population health into medical school. And I actually ran the first block of medical school, trying to get that into the curriculum. And it's there to some degree. But, there's a tradition among physicians that if you're my patient, I don't care about anything outside of you, okay? I'm gonna order whatever I think you need. The hell, who cares what it costs, okay? Well, when you think population health, you can't think exactly that way. Now, it's more complex than that, and I use the term advisedly, because physicians have skin in the game, right? I mean, in a fee-for-service environment, the more you see, there are 3 ways to pay physicians, right? You can pay them a salary. That's what I get. The incentive there is to do as little as possible for as few as possible. Okay? You can capitate. And there you do as little as possible for as many as possible. Okay? And then there's fee for service, which you do as much as possible for as many who have money. And physicians are primarily Republicans in this country. Okay? They have been, up until recently, kind of independent entrepreneurs. Well, that's changing now. And I think the change in medicine is really going to occur when the current generation of students take over, because they view medicine very, very differently from people of my generation. And it actually goes to the saying of Max Planck, the Nobel Prize-winning physicist, who said, "Change occurs funeral by funeral." Yes, sir.
I think these abstract policy points are really interesting till it becomes all about the patient. My then says, heck with the rest of the population, I want the best care I can get, which is precisely what happened in the new screening guidelines. From an epidemiology perspective, very sound, but with the individual patient, under 40 mammogram not required. It's a very personal choice. So it's not that simple.
Oh, nothing is. But let me get to that idea of best care. Okay, so now we got CT scans. I mean, you can't go past a corner without finding a place where you could just walk in and get a CT scan or an MRI. MRI being magnificently remunerative imaging. Yeah. Well, you know, when you get a CT, and screening CTs are done all the time, put aside the fact there's no data that they're of any use. Forget that, okay? You get a CT scan, it's equivalent of 400 x-rays, 400 chest x-rays. We are now probably killing far more people from cancer related to radiation exposure from unnecessary CAT scans than we are finding anything that's useful, okay? Where I'm actually famous in the endocrinologic world is the management of patients with incidental findings. You get a CAT scan for something, and you find a problem in one of the endocrine glands, the adrenal gland, and we call them incidentalomas. Okay? And, you know, the amount of screening tests that are done once you find one, it's all cost, benefit, virtually nil. So, best is in the eye of the beholder.
Yeah. And as a community and society, we're used to that notion of best.
Right.
Whereas in India, where I come from, the notion is very different. The family physician says, no, you're not going to make it, life goes on. You don't get a second opinion, third opinion, try to hope for the best.
Mhm.
It's a very complex issue.
Yep.
But isn't it changing very much?
It's becoming, again, going for the best.
Yeah.
So it's about mindset again. So, I mean, if you think about it, the theme for today has not been sustainability or complexity. It's all about mental models. We don't believe what we see. We see what we believe. All right.